a study, the seroprevalence of hepatitis C virus was found to be 0.62%, similar to Podar et al., Giri et al., Kaur et al. Our study showed the male dominance, that is 93.2% in blood donation, similar to studies of Saini et al., Sinha et al. Seroprevalence was found to be higher in replacement donors as compared to the voluntary donors, similar to Kumar et al. In our study, 53% of donors belong to 21 to 30 years, similar to Kamarkar et al., Sinha et al. And highest prevalence of hepatitis C virus was observed in the age group of 21 to 30 years, while Sinha et al. Found it in the 31 to 40 years. Seroprevalence of hepatitis B virus was 0.46, lower than most Indian studies. Co-infection of hepatitis B and hepatitis B virus and hepatitis C virus was not found. Co-infection of HIV observed in one male replacement donor. Conclusion. Our study reflects higher prevalence of hepatitis C virus among the replacement donors. So, motivating voluntary blood donors by conducting voluntary blood donation camp is the most effective method of ensuring adequate supplies of safe blood and blood components for transfusion. These are my references. Thank you.
Thank you. Any questions? Okay. Thank you, Doctor.
Next, I call upon Dr. C.P. Ganesh. He will be presenting on endocrine and metabolic changes of thalassemia in Manipur.
Very good morning to one and all present here and all the dignitaries and delegates. Today I am going to present on endocrine and metabolic changes in thalassemia patients in Manipur. Introduction. Thalassemia are a group of inherited hemoglobin disorder which is mainly because of the decreased or absent synthesis of normal alpha and beta globulin chains of the hemoglobin, and others due to the structural hemoglobin variant like hemoglobin S, C and E. Various thalassemia phenotype may arise due to the simultaneous inheritance of two different thalassemia mutations from each parents, or co-inheritance of thalassemia together with the structural hemoglobin variants, say like beta thalassemia along with the structural hemoglobin variants like S, C and E. When we classify thalassemia syndrome, we can classify broadly into that non-transfusion dependent thalassemia and transfusion dependent thalassemia. Among the non-transfusion dependent thalassemias like alpha thalassemia trite and beta thalassemia minor are the major chunk of the disease, and occasional transferring requiring diseases like mild HBE along with the beta thalassemia minor and mild HPC along with beta thalassemia minor, and intermittent transfusion requiring includes the deletional HBH in which the 3 genes of alpha is getting deleted, and along with this, that moderate HBE with beta thalassemia also requires intermittent transfusion. Other diseases like non-deletional HBH and beta thalassemia major and severe HBE and beta thalassemia coinheritance as a lifelong transfusion dependent thalassemia. So, pathophysiological mechanism by which the thalassemia causes various metabolic and endocrinological changes includes the red cell is altered. That means like alpha and beta globulin chains are not perfect in the cell. So, because of this red cell pathology, there will be the hemolysis, and because of which there will be anemia, because of which there can be reduced tissue oxygenation, because of which there can be erythroid marrow expansion leading to hepatosplenomegaly, extramedullary hematopoietic and pseudotumors, and because of this there can be enlargement of the bones leading to the bone deformities. In other side, because of the increased iron overload, because of other transfusion dependence like this, there can be diabetes, which is commonly called as bronze diabetes, growth deficiency and other endocrinological problems, mostly because of the iron overload depositing in the glands, and there can also be leg ulcers, thrombotic events, pulmonary hypertension, and due to the hypercoagulable states. This is an observational study conducted in Jenims, attending the medicine OPD and along in the medicine wards. The study period was from August 2019 to February 2020. The materials and methods. The inclusion criteria includes those patients who are having beta thalassemia major, HBE along with beta thalassemia those with the minor beta thalassemias and alpha thalassemia trait were excluded. Other hemoglobin E trait and hemoglobin E disease were excluded, and patients who are not willing to participate were also excluded from the study. So the diagnosis was made on basically on clinical history, CBC and reticulocyte counts, and HB electrophoresis and HPLC. Monitoring of the patients was done with LFT, KFT, and like viral markers and serum ferritin, thyroid profiles, and blood sugar levels. A diagnosis of endocrinal metabolic disorders were made through, we mainly took in accounts for 4 main things, like evidence of growth failure, in which the height below 5th percentile of WHO growth chart, evidence of diabetes mellitus, fasting glucose being more than 126 or non-fasting glucose more than 200 milligram per deciliter, and exogenous insulin administration or use of oral hypoglycemic agents were included. Evidence of hypothyroidism on ongoing thyroid hormone replacement therapy of more than 10 microunits per liter were taken into consideration. Evidence of hypogonadism as per standard guidelines using the Tanner's grade was taken into this account. On this observational study, we found that the age group of 5 to 10 was mostly affected in my study. On socioeconomic status, the patients who are living below the poverty line was mostly affected, and the people from rural areas has been affected more. And when we studied more basically among these 4 major types, like in which the mild HBE along with beta thalassemia had a major chunk in my study, accounting for 63.1% of the total study population. And when we go on to the therapeutic characteristics, here we see the normal average hemoglobin of different categories of thalassemia, in which we can see that as the disease get a bit severe, like beta thalassemia major or beta thalassemia along with severe HBE, their hemoglobin levels also accounts to that. Like for example, if you see here, the mild E along with beta thalassemia had a bit okay ferritin level, like say 600 within that range, but beta thalassemia major had a major junk like approximately 1500. In this study, we see that blood transfusion is mostly required for beta thalassemia major and severe E beta thalassemia group of peoples, when compared to that mild people doesn't require that much transfusion. And endocrine and metabolic changes in the thalassemia syndromes, in which we can see that patient with mild E beta thalassemia had three people in my study had diabetes mellitus, and mostly the bone changes and this in the hypogonadism and hyperthyroidism were documented in short growth stages, was documented in severe diseases like beta thalassemia major and severe E beta thalassemia. So iron overload is mostly seen who receives more blood, indicates that the beta thalassemia, the blue color in the bar graph indicates those who had iron overload, and the orange color indicates that those who didn't have iron overload. From this we can understand that patient who received most of blood transfusion had more iron overload, like beta thalassemia major and severe E beta thalassemia. Then other complications like facial deformity were also high along with severe E beta thalassemia, and HCV infection was seen in the patient with mild E beta thalassemia. Here we come for the hydroxyurea and its complication. First of all, the hydroxyurea responders are those who hemoglobin increases by 1 gram per deciliter after 6 weeks of hydroxyurea treatment. In this we can see that responsiveness was found in 45% of the people and non-responsiveness was seen in 11%, and side effects like mild gastrointestinal symptoms, mucocutaneous changes was also seen. Discussion. In my study, the prevalence of beta thalassemia major is low compared to other states of India, but HBE beta thalassemia was is seen more among those people. It is also less when compared to other states like Assam. It may be because of my small study population. So start stature, diabetes and hypothyroidism, hypogonadism is the most common endocrine complications in our study. The endocrine abnormalities like start stature, hypothyroidism, hypogonadism are quite less in our study, which may be less because our study has majorly HBE beta thalassemia and very less number of beta thalassemia major and severe HBE diseases. Prevalence of diabetes mellitus was comparable with the previous studies. The prevalence of other endocrinopathies like amenorrhea were much lower when compared to other studies. In our study, the responsiveness of hydroxyurea was 40 to 60%. In other studies, which is in our study it was 80.4%. These were my references. Thank you.
Okay, thank you, Dr. Ganesh. Any question from the audience? Dr. Ganesh, you have said that the complication of this, the presentation of this thalassemia, one is growth hormone deficiency and growth hormone deficiency. Yeah. And you measure the short stature as the criteria for growth hormone deficiency, no?
Yes, sir.
But you say a patient of thalassemia, okay, this patient will have short stature. Okay.
Yes,
it's a part of the disease, okay? Patient will have short stature, but these people, usually the growth hormone deficiency is not there, okay? You do the stimulation test and all those things, everything comes normal. So it is some sort of growth hormone resistance, okay? Because also many things are there, okay? And regarding your hypogonadism, okay? So you measure any hormones, any?
No, sir. Clinical. It was done clinically with the Tanner
That will
gauge,
be
sir.
very difficult again, okay?
Yeah, yeah, sir.
So in PGI, they are study, actually this was done by one of the, he's a student from Manipur only, and they found that they see the hypogonadism, whether it's primary or secondary. Secondary means some diseases of the pituitary, primary diseases of the testes and all those things, okay? They found that even in this thalassemia, the major cause was secondary hypogonadism. There was some problem with the pituitary also, okay? Anyway, it was a
Thank you.
nice presentation. Thank you.
Thank you, sir.
So we have come to the end of the first session of Amamicon. I'll just take a call from one of the senior members. Sir, question hangada bro sir. Yeah, just got a call from one of our senior IMA member, Dr. Navkanta Sharma. He has high praise for Dr. C.P. Ganesh, who has been one of the most this thing in the COVID ward at Jennings. He has been on duty, it seems, most of the time. So a special applause for Dr. C.P. Ganesh.
Okay, it is 9:55 and we are early. We are supposed to finish at 10. The whole session and speakers, they have spoken very well. I would like to call upon Sir Dr. Tondon to kindly felicitate our chairperson. Sir, please felicitate our chairperson, sir. Sir. Chairperson, felicitate them to sir. Sir Tondon, sir, a senior eye specialist. Sir, please, sir. First, I'd like to call upon Dr. A. Vivekananda Singh. Sir, next, Dr. L. Ramesh Sharma. Thank you, sir. Thank you very much. Thank you, chairpersons, for a wonderful session. We'll be inviting you again next year. Sir. Hoy, sir. Team talk. Sorry, happily. Ngali sa pung tarata adri sa. Sa karamba haptan sida haptan.
Si makali orang orang dia biwa. Makali dia biwa. IMA sih sih. Betul tu ya. Yang sih kau. Macam ya.
Sadu di si semaina minimize to lagi.
Okay.
Di si thol lagi.
Semaina tu pero. Jadi semaina tu ya, Pak.
So all the speakers, all the presenters can collect their respective certificates tomorrow from the counter, okay?
Good morning, everyone. Now we will start the second session, Team Talk. May I have the privilege to call upon our chairpersons, Dr. Y. Mohan Singh, retired professor and HOD, Pathology, Jennings. Dr. C.H. Manglam, retired professor, Department of Obstetrics and Gynecology, Jennings. Dr. Santan Auram, professor, Department of Medicine, RIMS. So now I hand over the time to the chairperson.
Good morning, everybody. To start with this theme talk, let me introduce Dr. K.H. Birendra Singh, Professor of Medicine, RIMS. He worked as physician in Manipur Health Service from 1989 to 2001. Joined RIMS in 2002. Presently involved in the management of the COVID-19 at RIMS as a nodal officer. Dr. Birendra.
Respected chairperson sirs, my dear IMA brothers and sisters, friends, ladies and gentlemen, very good morning to all of you. It is a great privilege for me to have been given the task of delivering the theme talk, Living with COVID-19, in this edition of 36 IMA MANIPUR 2020. For this, I'm very grateful to the members of the scientific committee and to our president. We all of us know that coronavirus disease 2019, because it was first detected in the year 2019, also known as COVID-19, is caused by severe acute respiratory syndrome coronavirus 2, or in short, SARS-CoV-2, which produced an outbreak of atypical pneumonia in the city of Wuhan in China in December 2019. Seeing the atypical nature and the severity and also the transmission pattern, WHO recognized this COVID-19 and declared a public health emergency of international concern on 30th of January 2020. This is a representative picture of our world affected by these blue dots here. Large dots means large number of cases, concentration in Europe. This was a little taken a little earlier, and here concentration in India and all. So this is spread to almost all countries of the world or regions of the world except for Antarctica. Today, in the globe, there is a total of 770 million cases and 1.59 deaths, which comes to approximately 3% of the infected persons. In India, 9.8 million cases are recorded with 14 lakh deaths, and occupies the second place next to the USA, which records a total number of 16.06 million cases with 29 lakh deaths. In Manipur, in our state, the first case was recorded on 23rd of March 2020 in a returnee from the United Kingdom. And today, the total record number of cases is more than 26,000 with loss of 320 fishes' lives prematurely. The disease has not spared high and low. Even the president of the USA, Donald Trump, was infected. The president of Brazil, Jair Bolsonaro, who was infected 2 times also. And Prime Minister of the UK, Boris Johnson. In India, we have got high-ranking peoples, VIPs, even the Home Minister in our state also. Even the high-ranking officials and VIPs have been infected. So this is a electron microscope picture of coronavirus impacting the epithelium. As we know, SARS-CoV-2 is an enveloped RNA virus. This binds to the receptor, which is known as angiotensin converting enzyme 2, which is principally expressed in airway epithelial and vascular endothelial cells, where replication occurs, leading to lymphocytic endothelialitis, coagulopathy, and cytokine dysregulation. This produces a variety of symptoms. This is a picture of the life cycle of the virus binding to the ACE2 enzyme here, and the replication occurs, and there are various sizes of actions of the drug. For example, here inside the cell is hydroxychloroquine X, and in the transcription and replication stage, remdesivir antiviral virus is effective. Same picture here. And the transmission, as we all know, occurs to the respiratory droplets in sneezing, in coughing, or in even talking also. Some of the uncommon symptoms, besides the common ones, we have got anosmia, loss of smell, ageusia, loss of taste, GB syndrome, confusion. We have got cases of seizure and CVA, encephalitic form, achy eye, deranged LFT, myocarditis, even myocardial infarction, diarrhea, conjunctivitis, and skin changes, also known as, in some cases, COVID-2s. This is a picture here, RIMS and Jennings here. These 2 hospitals, tertiary hospitals, have been identified as COVID treatment hospitals, dedicated COVID hospitals. But here, in a study recently, we have seen that most of the cases, as many as 82% of the cases were asymptomatic or mild, and 15% were moderate to severe, and about 3% were critically ill. In that study, we have seen that here asymptomatic is 70%, mild cases 17 cases, altogether 87%. Moderate in this study was a little less, about 3% only, and severe we are 9%. This may be because the admission pattern here in our college was because we accepted the more severe form, moderate to severe or critically ill patients were admitted, so the study came like this. And comorbidities, because of the comorbidities, so they deteriorate very fast. So commonest associated diseases were hypertension and pre-existing diabetes, mostly uncontrolled, and liver disease in form of chronic liver disease, COPD, CKD, renal disease, those having coronary artery disease or respiratory disease like tuberculosis, and some of the cases had malignancy. So this is a picture, X-ray taken in a serious patient. So bilateral opacities were there in the ICU, COVID ICU here. The same thing here, bilateral involvement. So as much as about 80% of the lung tissue on bilateral pulmonary infiltration were occurring in this case. And this is a picture of a very severe form of COVID-19. So in X-ray, we have got PC infiltration, consolidation, interstitial changes, even pleural effusion may be there. Total lung opacification we are seen also. Ground glass opacity also in the CT scan, mostly affecting the peripheral and the posterior regions of the CT scan we are seen. This is a CT scan picture of one of our patients. Here, in this cut section here, about say 80%, about 80% or 75% of the lung on both sides are involved by this corona disease, and unfortunately we lost this patient. What are the indicators of severity? So, age more than 60 years of age, and then some of the biochemical indicators are the level of procalcitonin indicating inflammation or infection, the level of the dimer, and CRP and LDAs, and then the ratio of neutrophil lymphocyte ratio more than 3 or 3.5. These are indicators of severity. In the treatment section, the wide range of molecules have been tried, including convalescent plasma infusion, hydroxychloroquine, ivermectin, antivirals, and the research is still going on to find a new remedy, yet no specific remedy has been found so far. And they have shown that dexamethasone, simple corticosteroid, showed improvement in survival in very severe form of COVID-19 cases. And WHO's solidarity trial showed that remdesivir we use as a panacea in the early stage, it is found that remdesivir, hydroxychloroquine, lopinavir also, and interferon regimes, this had little or no effect on 28-day mortality or in hospital course of COVID-19 among hospitalized patients. But still, since we don't have a remedy, we are still using these molecules here. And one important thing to note for all of us is that oxygen remains the mainstay of treatment in moderate to severe patients, because hypoxia is the most important presenting symptom. In this study, again, done recently in our hospital here, so far we have emitted 1,500, more than 1,500 patients. So we have analyzed 815 cases. So of these, 80% of them, they were quite normal or doing well in the room ER, so as much as 80%. And 7.8% people, they needed face masks with oxygen, and non-rebreathing masks was used in 5.8%. Non-invasive ventilation was used in 5.2%, and 10% were in intubated, amounting to 1.2% of the cases. Commonest one is face masks and NRBM in our case. Here, duration of the patients remaining positive in our setting was 12.55 days. Though extremes were there, so some people became negative in 1 week's time, or some people became negative in 32 days time. So now physicians or treating doctors are faced with post-COVID sequelae. Many people, they become test negative, but they cannot be discharged because of still persisting hypoxia. So they present with persistent exercise intolerance, means they cannot walk, they cannot climb stairs. They have got cough, and they have got restlessness, breathlessness. They have got anxiety, palpitations, poor concentration, mood swings, and fatigue, and muscle and joint pain, headache, brain fog in some patients who recover. These are new problems encountered by the treating physicians. So in this scenario, vaccines bring new hopes. So this is a picture of Margaret Kennant, that old 90 years old British lady. She was given the first sort of Pfizer vaccine. She said that this is the greatest gift of her coming birthday. That is 91 years. So we have got 4 or 5 vaccines in the picture right now. So one is Pfizer BioNTech vaccine, is a messenger RNA-based vaccine, and this is received recently emergency use authorization in the UK, and other countries are also following suit, including the US also. Sputnik 5 is a live attenuated vaccine developed by Gemelli Research Institute, and it is already approved in Russia, and the first shot was this thing given to the daughter of Mr. Putin, President of Russia. Dr. Reddy's laboratory in Hyderabad is evaluating the efficacy and its appropriateness to be used in Indian setting. Serum Institute of India is working with Oxford AstraZeneca vaccine. The name is known as Covishield, and this is adenovirus vector-borne vaccine. And also, Bharat Biotech, Indian pharmaceutical company, is working in an inactivated live vaccine, and the name will be Covaxin, and it has entered the terminal stage of phase 3, and we are hoping for this thing Covaxin to be available in the near future. Generally, 2 doses of vaccines are given. Dose is about 0.5 ml, with this thing 28 days gap in between the two, and in case of 21 days, in case of Pfizer and Sputnik 5 vaccine, the gap is 21 days. But some problems are there in this thing Pfizer vaccine because the preservation and the transportation needs a very low degree of preservation. So minus 70 degrees Celsius should be maintained for its efficacy. In the pill, minus 20 degrees should be available, should be kept, and when once opened, it should be used in 1 day or 2 days time. For Oxford and Sputnik 5 vaccine is maybe suitable for in our setting because 2 to 8 degrees is quite convenient for the health system in our setting. Coming to the pandemic, this thing, COVID-19, it has reached a pandemic proportion, and this is the severest form of pandemic in the last 100 years, and it is marching ahead very relentlessly. In the first half of the pandemic, say from the first 6 months of the pandemic, the government, the authority in many places, they have resorted to lockdowns and ban on gatherings and close down schools and colleges, and also the industry also. This effect to some extent slow down the infection, save many lives, and gave the authority or the health system time to stockpile equipment and supply. For example, initially we didn't get PPE properly, we didn't get face masks, we didn't get ventilator, but now that time was utilized for this thing, getting these supplies. But there is no end inside of this pandemic, so this is expected to linger, maybe for a few years, or even so no one knows. So because of the pandemic, the result is economic, socio-economic, and other also, of course, the social in contraction is there, and there is soaring unemployment, health and healthcare issues are there, children and higher education are affected, and many more. And there is a visible social change, and actually the impact occurs in every sector around the world. Healthcare providers, doctors and nurses, these are the frontline workers, they are the people who actually handle the cases, interacting and treating the cases. So many of the doctors and nurses and staff all over the world, they are infected with coronavirus. This is quite natural. WHO recognized this one and reported that out of 10, 1 in 10 ICPs may be infected or were infected in some countries. And as far as our college is concerned, we had a record of 163 doctors, nurses, and supporting staffs. 63 we are doctors, of course, remaining we are nurses and supporting staff, and they were infected. And fortunately, 1 or 2 of the doctors or distinguished staffs, we are in the moderate to severe form. Others, we are mild to or asymptomatic, and they recover very nicely. And the effect of coronavirus on this healthcare providers are mainly twofold. One is physical, another is mental. In physical, wearing this thing PPE for a prolonged time, so they have got a duty from 8 hours duty. So in the morning, the evening, and the night time. So minimum of 8 hours. So wearing PPE for a longer time for of this duration during summer is a very cumbersome problem because it's very warm. They cannot breathe nicely, and they cannot go to the washroom and very warm. But maybe it's a little better in winter season. But wearing properly PPE means may produce skin changes. For example, changes are skin on the face, especially over the breeze of nose and all. On the mental side, a lot of stress and fear and anxiety regarding the patient himself, regarding the doctor himself, and for his or her family. There may be insomnia, depression, and exhaustion, and a lot of other psychological problems may be there. We have seen untimely loss of precious lives among doctors. So we have lost 5 very prominent colleagues in our state, and the 6th one was a doctor, but he was not actually in touch with the patients. And in India, they have reported. They have reported that as many as 382 doctors have succumbed to this unfortunate disease. And this may be explained by the higher pathogen exposure, staying in the COVID ward, and other factors also. And doctors and healthcare providers have faced ostracism and stigma more than clapping and applause. In some cases only we have received clapping and applause. Otherwise, most of the places there have been stigma. For example, nurses are not allowed to enter the laikai or community or the family by their neighbors, by their local clubs, because they they work in the COVID ward, so they may be the carrier and the focus of infection in that locality, like that. Even violence and abuse and several challenges have been faced by the doctors and nurses. Fortunately, the government has passed an amendment, this thing for protection of the healthcare providers against violence from the uneducated public. In the healthcare system, in our setting, there's lack of dedicated COVID health centers, lack of dedicated COVID hospital. Only 2 are working, so for a population of 30 lakhs and presently 26,000, so it's not enough. There is a mixing up of COVID and non-COVID patients in the these 2 or available health centers. So necessarily the chances of infection to the non-COVID patients will be still large. And there is the large infrastructure constraint because the hospital structure was not planned on COVID because he was not there, he was not foreseen also. So we are working in the present, already present infrastructure, dividing parts of COVID and non-COVID part necessarily, the problem is there. So many people are involved in the management of COVID and remaining non-COVID. So there's a manpower constraint. Because those who have been posted in COVID ward, they have to go for quarantine for a certain period time. So in this setting, most of the hospitals have closed down the normal OPD and normal OPD. Necessarily, those patients who require regular checkup like hypertension, diabetes, chronic kidney disease, chronic liver disease, and elective surgery, so they suffer, so they are not attended, and so most of them deteriorate. So for example, 1% of the diabetes mellitus which was under regular follow-up in the OPD has deteriorated many a time because the blood sugar is not controlled entirely, and it is seen that nowadays those who are having high blood sugar and got infected with COVID so they fare unwell, less well than those who are with tight control of diabetes. So some of the papers, they say that those who are having more than 140 milligram of blood sugar, glucose in the blood, they suffer more, they deteriorate faster than those who are having blood sugar less than 120. So in the obstetric and gynae section, of course, pregnant women, they cannot undergo regular antenatal checkup, so they cannot find out which one is complicated, which one is having breast presentation, placenta previa, and so forth. And so at the end, at the time of the labor, they present to the hospital so with a lot of problems for the doctors as well as for the patient and the patient party, and a lot of misunderstandings develop between the patient party and the hospital setup. So among the pediatric group also, routine immunization is not held nowadays. So I don't know what will happen to the poliomyelitis or measles and so many things which was undertaken earlier also. And those who are undergoing cancer treatment and oncology follow-up, so they need a regular follow-up also. This also have been curtailed. And those HIV infected patients, they should have very regular ART regimen, so they cannot stop it. So maybe 1 or 2 days. If they stop 1 or 2 days, then of course there may be chances of mutation, and so there may be resistance. So nowadays the people HIV infected patients getting first lines are declining because of the resistance. So in the recent setup, so many people they are failing on the first line, and so they are moving to second line, then maybe to the third line also, but at present there is no fourth line. So the many people in HIV infected people on ART are having lot of problem. And this is not the end. So it affects all the departments in this thing. In the mental side also, there is a lot of depression, anxiety about disease, lots of insomnia, somatization problems, other psychiatric conditions, and even domestic violence are on the rise in the community, also among the doctors and nurses and staff. So unfortunate events are coming up. For example, some of the one of the these healthcare providers wanted to commit suicide, and luckily he was saved. So many incidents are coming up to our knowledge. So for the management of such things, the experts have advised psychological support to the individual, maybe doctor, maybe nurse or the staff, out to the general population. Physical exercise, yoga, and maintaining a hobby, and maintaining a good diet and nutrition maybe helpful in the setting. So, social impact, social interaction affects many areas of our lives, impacting on workplace, home life, and many day-to-day activities. There is erosion of this age-old social custom. For example, there is no visible smiles, human touch, handshake. These are very critical to social cohesion and social well-being. So this is a picture showing here Emmanuel Macron, of President of France, and Prince Charles and Duchess of Cornwall, Comela. So they are keeping this thing, a new greeting, new form of greeting. For example, they are not doing handshake; they are doing namaste. And here also another official from Africa is greeting Prince Charles. I'm sorry that they are not keeping wearing masks as they should, but they must have taken out at this moment. So now we are going to have a new normal. So the authority, the government have this thing allowed, graduated, unlocked, more and more social mobilities are here allowed. And so at the same time, there will be more spread of virus in the community. So the battle against COVID-19 is entering a new phase. The choice for society is to live with the virus or to live for the virus. Is There is no activity without risk of the coronavirus in our setting. So we have to figure out a way to live with this pandemic. So life with COVID-19 is a new normal. So masks at all times have become essential and rather fashion. So many people are wearing very customized masks also. Even the bride and the grooms are wearing customized masks at the marriage ceremony, wedding ceremony. And sanitizing hands frequently may have changes, dermatological changes, and the hand and somewhere, and social distancing. So masks at all times, sanitizing hands, social distancing. So this is the new normal life for us. So this will remain for quite some time to come, as many experts foresee. So everywhere we have to wear masks. And we cannot and wearing masks properly also here. Social distancing in any event, important event, so social distancing is a must, a distance of 6 feet from one another. And regarding telemedicine, so in healthcare system, telemedicine, which was present earlier, also now new way to take television is a new way to consultation at maybe a lower cost. It allows patients to consult doctors in any part of the world, but it has got many drawbacks as well. For example, if you want to examine a patient practically, physical examination, these are lacking. But psychiatric patients, they will do very nice in telemedicine consultation, and surgery cannot be done in telemedicine. So many drawbacks may be there. In the academics conferences, just like ours now, so CMEs meetings or teachings and learning, they will be held via different online platforms, like for example Zoom meetings. And on the other hand, this has got uncertain reality. Of course, it's very useful, but in practicals, it has got certain drawbacks. In India, they have seen that as many as 32 crores of students, they have stopped going to schools or colleges. Classroom teaching is been replaced by distance teaching and learning. Exams are postponed or held very partly only. And the challenges for the teachers and the institutions and for the students also is access to the technical infrastructure. So many people, many students may not be having a very good phone or laptop, or the teachers have been trained in the new technologies. So in the school also, so every students they have to have this temperature monitoring at the entrance, the social distancing and all. International mobility, especially for the students, have been reduced drastically. For example, medical students studying in Russia, China, Ukraine, Belarus, Bangladesh, or any other country from Manipur, they are still having difficulty in attending classes and going to their institutes, especially in China, because there is a tussle between China and India at present. Research and the PG thesis works, they've been hampered. Office-based business, and for this one, work from home have been utilized, and so there will be fewer employees at office. Fewer employees means fewer meal-eaters at restaurants, economic problem, fewer shoppers in the stores. So on the brighter side, parents working in office, they are enjoying family and working at the same time also. In the economy, e-commerce and a digital economy will ensue, and greater adoption of automation, robots, and artificial intelligence in factories and workplace will be predicted. Of course, they will have ethical and privacy risks also. Questions will be raised. Will technology give us the same quality of social interaction that are important to social wellness? So these are humanoid robots developed by this thing, Achievement of Robotics in Kochi. These robots are distributing masks, sanitizers, napkins, and food, and they are monitoring temperature also in the COVID ward. For travel and tourism, so destinations, tourist attractions, hotels, airlines, all will change drastically, affecting the tourism and business. In cultural attractions also, they will suffer due to reduced worker population and also visitors, and impact on senior citizens in our setting. So these are vulnerable group of our population. They've been stopped from attending ceremonies like in our Manipur, weddings, radhas, community peace, and all. So in a study done recently in our college, so there were 79 deaths. Of these, less than 46 deaths, 41 to 59, 30 deaths, and 60 years and above, there are 43 deaths, accounting to more than 54.4% of the mortality we are accounted by the elderly people. So in colleges and offices and schools, so the attendance will be taken by facial recognition system, the new Roman. This is the Jana Andolan. Yes, sir, coming to the end. Few more, 1, 2 slides, yes, sir. And wear this thing marks properly, regular hand washing, and maintain these things. And here I want to end with one quotation. In this scenario, we all have a part to play in the interconnected world to be more responsible, accountable, getting closer to the nature and create better connectiveness in our communities to improve the quality of life for everyone. Thank you very much, and long live IMA Manipur State Branch. Thank you.
Thank you, Dr. Virendra, for a nice and very informative information that you given in your lectures. And thank you so much when you delivered the lecture. Okay.
Thank you, sir.
Yeah.
So there was a very informative talk from Professor K.H. Birendra Singh. This being a theme talk for whole conference, we will not entertain any questions. Thank you very much, Dr. Birendra.
Thank you, sir.
Sir, let me go, sir. Sir, please, sir. Sir, let me go, sir. So I would like to request Dr. Sam Kumar Laishram, President, IMA Manipur State Branch, and Dr. N.G. Arun Kumar Singh, Honorary Secretary, IMA Manipur State Branch, to kindly felicitate Dr. K.S.H. Birendra Singh, the speaker of our theme talk, Living with COVID-19. Sir, please. Sir, let me go, sir. Now I would like to request Dr. Sam Kumar Laishram to kindly felicitate the chairpersons of today's theme talk, Professor Y. Mohan Singh. Sir, sir, let me go, sir. Professor C.H. Manglem, sir. And I would like to request Dr. N.G. Arun Kumar Singh, Honorary Secretary, IMA Manipur State Branch, to kindly felicitate Professor Santa Naurem. Okay, okay. Thank you, sirs, for chairing a wonderful session on our theme talk, Living with COVID-19.
So we shall resume our program. The next session will be Professor Jatishwar Singh Memorial Oration. We will listen to a topic, COVID-19 and pregnancy. Now may I have the privilege to call upon the chairperson, Dr. Shyam Kumar Laishram, President IMA Manipur State Branch, and Dr. N.G. Arun Kumar Singh, Honorary Secretary IMA Manipur State Branch. Now I hand over the time to them.
ꯆꯥꯒꯤꯔꯥ ꯑꯗꯨ ꯅꯪ ꯍꯥꯟꯅ ꯄꯤꯔꯛꯀꯗꯕꯅꯤ ꯀꯩꯅꯣ ꯇꯧꯔꯤꯉꯩ ꯇꯧꯒꯗꯕꯅꯤ ꯅꯪ ꯍꯥꯟꯅ ꯄꯤꯔꯛꯀꯗꯕꯅꯤ ꯑꯩꯅ ꯁꯤ ꯇꯧꯔꯤꯉꯩ ꯇꯧꯍꯧꯒꯗꯕꯅꯤ ꯀꯣ ꯀꯅꯥꯅ ꯅꯈꯣꯏ ꯄꯥꯔꯇꯤ ꯀꯗꯥꯏ ꯃꯇꯩ ꯁꯤꯗ ꯇꯧꯅ ꯑꯇꯩ ꯀꯗꯥꯏꯅꯣ
Good morning, all my respected teachers, seniors, and friends. Now we'll be having Professor K.S. Jatiswar Singh Memorial Oration. Professor, today we have Dr. N. Kishore Singh. He'll be delivering the oration. I'll give a brief biodata of Professor K. Jatiswar Singh. He was an eminent obstetrician and a gynecologist. He is one of the senior-most gynecologists in the state of Manipur. He was born on 1st July 1935. He completed his MBBS graduation from Guwahati University. He was a diploma holder of the DGO Dublin University and diploma in obstetrics at CPI Ireland. He was awarded many fellowships like FRCS Edinburgh, FICS US, FICOG, FOXI India, FIC MICS India, etc. and etc. He gave his services at different places and at different levels. He was a medical officer in the state of Manipur. He also worked as clinical assistant at St. Anne's Hospital, London, Simpsons Memorial Hospital, Edinburgh, and Rotunda Hospitals, Dublin. After coming back from overseas, he worked in the state of Manipur as GDA MOI and Specialist Grade Officer under Central Health Service. Then he joined as faculty in RMC at present RIMS in 1974. He worked as professor and head for about 10 years till his retirement up to 1995. After retirement, Sir was very active and continued to service in humanity. He was chief of the ops and the gynecologist in the Catholic Medical Center, Koirengei and Langolview and Maternity Home, Imphal. He attended and published many scientific papers, both nationally and internationally. Many scientific papers were presented regionally, nationally, and internationally as guest speaker. He actively participated in various national and international congresses. Today, I am very fortunate and to announce the biodata of such an eminent person. Thank you.
Hello. We are lucky to have here eminent Professor Dr. N. Nabakeswar Singh to deliver the oration. And allow me to read out the brief biodata of Sir. Professor N. Nabakeswar Singh passed out his MBBS from Guwahati Medical College and MD from Varanasi Hindu University. He is also a fellow of International College of Surgeons, Indian section, and also a fellow of Indian College of Maternity and Child Health. He is a fellow of Indian College of Obstetrics and Gynecology and have published innumerable scientific papers both at national and international level. He has presented many scientific papers in national and international platform and was invited as faculties and guest lecturer in national and international conferences. He was a former professor and a head of Department of Obs and Gynecology, RIMS Imphal, and was also the chairman of Medical Society of the Institute. He was president of Indian Obstetric Gynecology Society Infant Branch, IOGS, and was also a former president of BPIN, BPAM Manipur State Branch. Now I request Sir Nabukeswar to deliver the oration. Thank you, sir.
Respected chairpersons, learned delegates, invitees, and ladies and gentlemen. At the very onset, I would like to thank the organizer for giving this privilege to deliver Professor K. Jatijo Singh Memorial Oration. Coming to the topic of discussion, COVID-19 and pregnancy. COVID-19 originating in the one city of the China has spread to almost every part of the globe. It affects more than 216 countries, and more than 62 million people are affected, causing 1.4 million dead because of this COVID-19. United States of America is the worst affected. India stands second position with 9.4 million COVID patients and 1.3 lakh dead. The declining phase of the infection rate is observed in the last 3-4 weeks in the state of Manipur, with varying new infections varying from 30,000 to 50,000 per day. The magnitude of the problem seems to increase gradually in the state of Manipur also. The number of pregnant women infected with COVID-19 is also at gradual increase. By November 2020, the total number of pregnant women with COVID-19 at two medical institutes of Manipur is 294. It is a high time for all of us to be united to fight for this dreadful disease. When we talk about fighting, it is not something like war. Here, we should be united together in performing all precautions to prevent this particular infection. That is very simple, easy things. That is the wearing social distancing for 6 feet. It is known to all of us, but only few people are practicing routinely. Unless specific curative treatment or vaccine is available, we have to develop something that can protect and prevent from this dreadful infection. The best way to prevent and slow down the transmission is to be well informed about COVID-19 virus and the disease, how it goes and how it spreads. This infectious disease, it affects different people in different ways. It spreads primarily through droplets of saliva and nasal discharge when the infected person coughs or sneezes. Maximum number of people develop mild to moderate illness and recover without hospitalization. Some develop severe illness and may succumb to death. The common symptoms that has been discussed in detail by earlier speaker, and I will just to recapitulate again, that is the common symptoms are fever, dry cough, and tiredness. Less common symptoms are aches and pains, sore throat, nasal congestion, diarrhea, conjunctivitis, headache, loss of taste and smell, etc. The severe symptoms of COVID-19 are loss of appetite, soreness of breath, persistent pain and patient disease, and high temperature more than 38 degrees centigrade. Now, let us see what is the prevalent situation of this COVID-19 over the globe. The total number of affected people is more than 62.9 million. The total number of deaths is more than 1.4 million. And in India, the total number of affected people are more than 9.4 million. And the total number of deaths is also more than 1.3 lakhs. In Manipur also, the same thing is true. And there is total of 24,500 is affected. There is data of November 2020. Total number of deaths is 263, and total number of pregnant women affected with COVID-19 is 294. And this is the slide showing the number of pregnant women affected with COVID-19. That is 294. Out of these 294, 256 has delivered vaginally or by cesarean section. And during this time, in the last about 3-4 months, there was only one maintenance that was encountered. And scientists around the world are working to find out and develop the treatment. And WHO is continuously monitoring and reporting about the pandemic, and questions and answers are updated about its spread and affection to the people. And now let's discuss on what are the effects of COVID-19 on pregnancy. Pregnancy affects body immune system. It also alters the response to the viral infections. These changes in the body system during the pregnancy may lead to severe illness of COVID-19. There are reported cases of COVID-19 pneumonia in pregnancy, and this group of pneumonia are very in the milder form with good recovery. Risks of mother appeared to increase in particular during the last trimester of pregnancy. There is no report suggesting the risk increase of pregnancy loss and the early pregnancy loss. And there is no data currently that the virus has teratogenic effect. There is no evidence that, or there is no indication that any patient who is infected with COVID-19 should undergo medical termination of pregnancy. But the reports of preterm birth have been associated with COVID-19. But it is unclear whether the preterm births were iatrogenic or whether the preterm births were spontaneous. Vertical transmission of the virus is probable, but the proportion of pregnant women affected and its significance to the neonate is yet to be determined. One interesting finding is that there is no recorded cases of vaginal secretion or breast milk being tested positive for COVID-19. But chance of affecting newborn is very low. This may be the probable reason. Elders, overweight, and pre-existing comorbidities like diabetics, hypertension, heart disease, and seems to increase the risk of severe illness of COVID-19 infected people. Heart disease is found to be highly associated with severe COVID illness, but this pandemic also increases the risk of perinatal anxiety and depression. It is critically important that supported women and family strengthen as far as possible. This is the slide showing the COVID-19 in obstetric department of RIMS Imphal. As we know, the first COVID patient was detected on 23rd March 2020. And following that, there was a gap of, after the gap of 3 months, the first pregnant woman detected with COVID-19 was on 27 July 2020. And first delivery on 10th August 2020, and first cesarean was on 26th. And the first maternal death encounter was in the month of November 2020. And this is the slide showing the outcome of the pregnancy. Out of the 135 pregnancy, 15 cases was found to be associated with some complications in the form of early pregnancy loss 3 and ectopic 2, preterm birth was 10. And these figures seems to be higher when compared to those reported in different studies. Neonatal outcome. And out of these deliveries, then complications arises in 8 cases. And stillborn being 2, gestational stillborn 1, intrauterine fetal death 1, and neonatal intensive care admission was 1, and neonatal death 1, and COVID positive neonates was 2. So this figure also seems to be very, very high. But for the confirmation of this, we need long-term studies. Data from the CDC, Center for Drug Control, suggests an increase in the risk of severe outcome in the pregnant woman with symptomatic COVID-19. It needs further analysis and peer-reviewed literature of the COVID-19 infection during pregnancy. Counseling the pregnant woman and those contemplating pregnancy about the potentiality of COVID-19 must be done, and measures to prevent infection should be emphasized. Testing. Guidelines are published by the CDC, who are the ones to be tested for COVID-19. Decisions about testing are at the discretion of the state and the local health department and the individual clinician concerned. What are the group of the pregnant ladies to be tested? Any pregnant lady who is having symptoms of COVID-19, any pregnant lady who has close contact with a confirmed COVID-19 patient within 6 feet for a total of 19 minutes or more, and those group of pregnant ladies have been referred or asked to get testing by their healthcare provider. These are the group of people who are supposed to be tested. What are the guidelines of the management of women in COVID-19 pandemic in obstetric unit? Appropriate isolation of pregnant women who have COVID-19 or who are the persons under investigation is very, very important. But we should know that isolation, it doesn't mean that they require a good care in the hospital. Unless there is repeat deterioration of the condition of the patient or a promptly failure to ship the patient promptly to the hospital. But isolation to contain the viral transmission must be recommended at the health facilities like community, local, or at home. And basic and refresher training for all healthcare providers is very, very important step for the correct adherence to the infection control practices and personal protective equipment use and handling. When such trainings are going to held to be, then videographic demonstrations will be very, very helpful and useful. Sufficient and appropriate personal protective equipment supplies should be positioned at all points of care, and at the same time, process to protect the newborns from the risk of COVID infection should be well planned in every obstetric unit. What are the guidelines given by the ICMR for the confirmed COVID-19 pregnant woman? Antenatal care must be minimized. There must be preferably 4 times during the course of pregnancy. That is at 12 weeks of pregnancy, 20 weeks of pregnancy, 28 weeks, and 36 weeks respectively. But now I want to remind here how many times we have to do antenatal care in a normal pattern. Once pregnancy is confirmed, the antenatal care should be once in every month. That should be continued up to 28 weeks, and from 28 weeks to 36 weeks, that must be fortnightly, patient should come for antenatal care. Once 36 is completed, they must go on attending antenatal care weekly till delivery. But this is for the uncomplicated pregnancy. When the complications are associated, it depends on the advice of the attending obstetrician. Pregnant women on symptoms of COVID-19 can be deferred with 7 days after the start of symptoms. And another group of pregnant women who are self-quarantined because of someone in their household has possible symptoms of COVID-19, appointment should be deferred for 14 days. When to consult or call healthcare provider? It is very important. And you think, once you think that you may have COVID-19, then it is time to consult. You think you are having depression during or after pregnancy, and you have any question regarding your health, that also time for consultation. But one thing I want to remind is, please don't delay your emergency care because of the COVID-19. Intrapartum care. What are the cares to be taken when patient goes into labor? The main aim is to keep the oxygen saturation above 94%. Titrating the oxygen therapy accordingly. If there is sign of sepsis, investigate and treat accordingly. If it's not responding, response is not good, then we must think or consider that this may be the probable cause, maybe the COVID-19 itself. So we have to investigate and treat. Continuous electronic fetal monitoring with CTG is a very essential. Mode of delivery should not be influenced by the presence of the COVID-19. Depending on the obstetrical indications, the mode of delivery should be decided. Appropriate analgesia, epidural analgesia or spinal analgesia are not contraindicated in the presence of COVID-19. But preferably in active labor, epidural analgesia is recommended because when there is any chance of emergency or requiring even emergency cesarean section, general anesthesia can be avoided. And in case of deterioration of the woman's symptom, the risks and benefits continuing labor versus emergency cesarean section should be decided by the healthcare team. And to occur short second stage of labor, it is the healthcare team who is attending has to decide what will be the best outcome of the pregnancy when mother is exhausted and become hypoxic. Either you continue the pregnancy for vaginal delivery, or you shorten second stage by giving instrumental delivery, or cut or finish up the labor process by doing cesarean section. That can be decided only by the healthcare team attending the patient. And now, after the delivery, how will to look after the newborns? This is also very important when the mother is having COVID-19. Many things are not unknown. Vertical transmission is probable, but still the number of infected with COVID-19 in the newborns are very low. Maximum number of the newborns who are COVID-19 positive have mild or no symptom and recover very soon. Severe COVID-19 illness of the newborn also been reported in different studies. That is to be kept in our mind all the time. Where newborn is to be cared, ideal setting of the healthy and full-term newborn during birth, hospitalization with the mother in the same room is a standard practice with precautions such as wearing masks and practicing hand hygiene. Healthcare providers should counsel about the risks and benefits of staying with the newborn in the same room, and counseling must be initiated preferably in the antenatal period. The benefit of the breastfeeding and the maternal newborn weaning must be stressed, and we all know breast milk provides protective in many illness in newborns, and moreover, it is a source of nutrition for all the newborns, and informed decision should be taken before we decide for anything. What are precautions to be taken when newborn are staying in the room? Hand hygiene is very important. Washing of the hand with soap and water at least 20 seconds before holding or care newborn is a must. Masks should be always used. Newborn must be kept 6 feet away from the mother. Even after the isolation period is ended, hand hygiene, other precautions must be practiced. What are precautions at home if mother is home isolation? Stay home separately from others, isolate from other household members. A healthy caregiver who is not at increased risk of severe illness must support hand hygiene, and use of mask by the caregiver is also a must. What are the precautions for prevention of COVID-19? This we should know. Prevention is better than cure, but there's no way to ensure you to have zero risks of infection. It is important to understand the risks and to know how to be as safe as to avoid infection. What are the precautions for prevention of COVID-19? The more you interact with, the more closely you interact with, and the longer the interaction, the higher your risk of getting and spreading the COVID-19. The preventive steps of the COVID-19 at present are limit the interactions when going out or interacting with others outside your immediate household. Wear a mask. Avoid others who are not wearing masks. Stay at least 6 feet away from others outside the household. Wash hands with soap and water frequently, and if not available, hand sanitizer should be used. And we have to avoid activities where the facilities for the personal protective equipment are not provided, and where social distancing for 6 feet cannot be maintained properly. To conclude, there's gradual increase in the number of COVID-19, including the pregnant women. Pregnant ladies with COVID-19 are likely to be severely ill. Most affected people are elderly age group and the people with comorbidities. And many COVID-19 patients are dying from different age groups of 50s and 40s and even less than 30s. The outcome of the fate of COVID-19 positive patients, either pregnant or non-pregnant, are very uncertain. We are all exposed to the risks of getting infection from this coronavirus. Each and every one of us should take all precautions to take and prevent ourselves from this dreadful disease until a specific treatment or vaccine is available. Thank you for patiently hearing.
Thank you, Tauna Kishore, for your very nice and lucid talk. Just one announcement. We had been doing this conference in a hybrid. We are doing online and offline to maintain the SOP of the COVID-19. And our now Facebook channel and the YouTube is going on, and there are a lot of viewers. And thank you, Tam, for your nice talk. Dr. Arun, please.
Now, if there is any queries or clarification, now, okay. So thank you so much for the oration that you have delivered. Now I request the scientific subcommittee, Dr. Umesh, to honor the speaker of the today's session.
I kindly request Dr. Shyam Kumar Laishram, President IMA Manipur State Branch,